introduce our speaker for today. We're going to do a quick round of introductions just so that you can let the Milliman team know your name and what concentration you're in. So let's do that really quickly first. I'll start here. You can just tell me your name and your concentration here.
My name is Emily and I'm a public health nutrition student. My name is Iris Liu and I'm concentrating in health policy and management.
Yang Zhang, Biostats.
My name is Michelle from Biostats.
Mine also about that.
I'm Contra, I'm studying about that.
Still on Biostats.
Shall we Biostats? Google Biostats.
So clearly we represent in the Biostatistics Department. For those of you who don't know me, I'm Melody Goodman. I'm the interim chair of the Biostatistics Department. Glad to have you all here. Our first speaker today is Dr. Jose Pagan, who is professor and chair of the Department of Public Health Policy and Management here at the College of Global Public Health. He's also the director of the Center for Health Innovation at the New York Academy of Medicine. He received his PhD in economics from the University of New Mexico. But before Dr. Pagan speaks, I'm just going to have Tia introduce herself and the Milliman team who's here today.
Hi, I'm Tia Sani, and I think you all know me because you've seen me a couple of times. But the exciting part, and you met Pamela at the last session, but we have 3 new Milliman team members here. Because we are really, really excited about this lab, and we can't control our excitement nor our attendance, which is a fantastic thing. So I'm going to have them introduce themselves. This is Bruce Pyenson.
Hi, Bruce Pyenson. I'm an actuary at Milliman, and I've been there for over 30 years, which is probably more older than you guys. I also wear a hat. I'm a commissioner on MedPAC, which is the Medicare Payment Advisory Commission, which has public meetings, 7 of them a year, on how Medicare payment is affecting the solvency of the Medicare program. So really thrilled to be here today. And Samantha?
Hi, I'm Samantha. I have an MPH in epidemiology. I graduated 2 years ago and I've been working at Milliman ever since. And I was really interested in being a part of this because I learned basic SAS and things like that when I did my MPH, but when they told me there was going to be sort of a more specific claims-based thing, I was really excited about it and also a little jealous that I wish I could have done that when I did my MPH.
Hi, my name's Eric. I've been working at Milliman for a little over 30 days, so a lot less than Bruce, and I'm here for about the same reason as you, because I'm still just getting my feet wet and trying to learn all this stuff.
That Eric and Samantha would be great people to talk to if you want to know more about our hiring and what we do and what it's like to be a relatively entry-level member of our team. And Bruce is a little bit modest because Bruce is also known as our boss. Jose, the stage is yours.
Thank you. Thank you so much for the invitation. I'm saying that I was expecting as much. Somehow I thought this was like, who's going to show up Friday? Like 4 people, we're going to be drinking water, eating something, and I'll show you a few slides. But I'll do this. I'll do the slides anyway. I'll show you what I had in mind. So I think what will be useful when you think about claims data is as you think about these examples, you will see how claims data is not only analyzed by people that are putting together reports, like the work that I'm going to show you now, but also by partners that we work with to do the work that I'm going to show you now. So I'm going to show you 3 examples, basically. One on a project that we did called Project Echo with a health plan. So before coming here, I work at a place called the New York Academy of Medicine, and we actually hire a lot of folks with public health degrees in every area, and PhDs, DRPHs, and so on in every field. And as I was listening to your areas, I can tell you that there's always a need for people that can think not only in terms of like this is how you do biostats, but can think broader than that. You'll see it in this example. So, how many of you have heard of something called Project Echo? None of you have heard of Project Echo? So I'll tell you about Project Echo. Project Echo. It actually it's something that came out of the University of New Mexico, and it's called Extension for Community Healthcare Outcomes. And it's a very interesting model on how to train healthcare providers how to train them to do something. So I happen to be involved in an evaluation of a Project ECHO implementation, as they call them, at the University of New Mexico. Well, the implementation was actually at the University of Rochester, and basically what they were doing is you have all these physicians spread out in rural areas in New York that have primary care physicians that they don't have access to a psychiatrist, and they don't have access to geriatric mental health care. So how do you train someone that is not going to have access to a specialist to deal with cases like that? So what Project ECHO does is basically they train physicians using what they call teletraining, or through video. So there's a team of experts basically that sits together and basically listen to a case. So for example, if I participate in Project ECHO, I'm a physician and I have a very complex case, I basically say, okay, here's the patient that I have. This patient, I think they have dementia, they're of this age, they're fighting with their family, they have all these issues. They take these 4 drugs, right? So what happens then is that a team of a psychiatrist, social worker, pharmacist, the whole team at Rochester listens to the case, provides advice, and because everybody's listening to that advice, basically they learn from each other about how to treat these cases. A written report is written, it's put together, so that information is provided back to the provider that is dealing with that case. The cases are presented, but they're they're de-identified. And then several weeks later, the case is brought back to see if the patient improved and so on. So if you think about it, it's a very interesting model because you can train folks to think about a problem and train tons of folks if they're able to basically connect over video. So here's an example of how the Project ECHO session looks like. That was one of the first ones that I went to. If you go to them now, they're really popular now, and they'll have like more experts than that. A room like about this big, and they have different flavors of ECHO. So who's interested in Project ECHO? Healthcare providers and systems are interested in this, and payers are very interested in this, because it's a way of like standardizing how care is provided. So in this case, Project ECHO for geriatric mental health care, they did it from 2014 to 2016. They had 33 tele-ECHO clinics, 520 attendees, and 65 patient case presentations. So they would do a case presentation, and after that they would do a didactic presentation. So for example, about how to deal with antipsychotics or something like that, at the second part of the session. And these are people basically sitting there in their clinic eating a sandwich and watching this thing at lunchtime. Okay? So so we partner basically with the New York State Health Foundation, Health Foundation for Western and Central New York, Rochester, and the people at Project ECHO at UNM, which basically tell you how to look at it. So I'll skip a lot of this. I'll get to it. We had access to, we did interviews. So when they teach you about mixed methods in your courses, that's what we were doing. We did interviews to see whether how the program worked, what participants thought about it, and then we were lucky enough to work with a health plan called Excellus Blue Cross Blue Shield, and they had access to claims data. So what we wanted to do was that if you were a clinic and you decided to participate in Project ECHO, then I knew the date you joined the clinic. I know that 3 or 4 of your providers showed up to the sessions. Then I could go back to the patients that belong to that clinic, and then I can find out how much they were spending in care before the physicians or healthcare providers were trained in Project ECHO, and after. So basically that's the design that we use. We didn't have any money to do a lot of this work, so we didn't think too much about a control. We tried thinking about control groups. At first we were like, why don't you give us all the data and we analyze it? And then we quickly realized that it was going to be very complicated. So what we figured out is, can we tell the health plan, how we want the data so that we could analyze it. So we didn't get into the nitty-gritty of how the claims data look like, but somebody like you was actually doing it at Excel's Blue Shield, so that you know. So we have data on 35 practices, and this is just an example of how the data looks like. So I think we looked at 6 months before and after. So we looked at patients that had some sort of code connected to a mental health condition. And we looked at things that the health plan care about and the providers care about, which is inpatient costs, basically hospitalizations, outpatient. And outpatient there means basically like any visit, ER cost and prescription costs. So you can see that the idea is then basically to look at, do you see changes before and after participation? And these clinics basically, they didn't join all at the same time, they joined over a series of months. So for every clinic, the sort of like the pre and post was a different time frame. Getting to that point requires the skills that you are learning in your degree, which is basically like, can you think about a program, think about how to design all the pieces, what are the indicators that these payers are going to care about, and so on. So so basically, well, I didn't say what it did, but they really focus on this issue of ER. I have another table where I show actual use, which you can get from claims data. So typically the payers and the providers are going to be interested in categories like that, depending on what it is. You know, hospitalizations is a big one, and then ER costs, prescription costs are becoming more important, so people are interested in that. And depending on how they look at the world, total cost of care. They may be interested also in quality indicators that you could pull from claims data. Okay, are people getting certain tests? And depending on the client you're working with, you know, if you listen to them, you'll be able to find out what they want to track. So the other component that I thought was worth mentioning, you know, there's a lot of controversy nationally about Project Echo. A lot of people saying, well, it doesn't work. A lot of the studies on Project Echo are not done on randomized using randomized controlled trials. But there's even an ECHO Act that was passed by Congress to support the model. So earlier this year, I saw this Health Affairs blog piece criticizing Project Echo that I felt was a little bit unfair, and so I wrote another piece after that. So it's a Project Echo enthusiasm overtakes evidence. So I call it Project Echo displays skepticism should not overtake its promise. and I didn't pick the picture there, which is not, anyway, that's not the issue. But the point is that if you want to learn more about ECHO, you can read that piece. It has a great summary. But to give you another example on how you use information like this, many times, like a lot of the work that we do, you know, you learn all these things in school, but the simplest things are what people are interested in. So you'll get people asking you, hey, can you tell me the ROI of that program? So this is the example that we have in that blog post. But a lot of it, you know, you learn it, so you go through the claims data analysis, and then you start thinking about, like, how do I explain what all of this means? Some people are going to be interested in reductions in cost. Some people are going to want to know, if I invest $1, how much do I get back? And sometimes, this is an artificial example because I didn't have a lot of data, but I know that the hospitalization to Medicare costs $10,000. But if you have more accurate data from claims, you could, you know, that could be $18,000. But it could be a different number depending on the population you're looking at. So let me show you the second example. The second example has to do with the program. Actually, I don't know why I'm connected to Rochester, but this example is also in Rochester. The same, it's a smaller than I thought, but bigger than I thought. So here's another thing that we do in our work. So there's a program in Rochester called Community Care Connections. Basically, you go to a doctor, and then the doctor says, the doctor knows that they should be connecting you to social services. So what Community Care Connections does is they connect patients. They have coordinators that they get referrals to community care connections, and then if you need food, housing, employment, care coordination, they connect you to that. So the state pays for it, Medicaid. And Medicaid basically says, you need to track if this is having an impact on hospital admissions. I told you already, right? Hospital admissions, ER visits, that's all they care about. So community care connections would report that information to them, but self-reported. And the state basically said, well, that's not good enough. You have to do it from claims data or some other data source. So they basically contracted with us to tell the state what they already knew from the self-reported data anyway, that this leads to reduced hospitalizations and so on. But that's what the state is asking, so you have to figure out, okay, how do I do that? So this is an example with claims data, but it's an example working with an organization called the Rochester Regional Health Information Organization. They get data from hospitals basically, and they're able to, at the local level, to calculate ED visits and hospitalizations. Basically the systems, they call it ADT, communication systems that are used at hospitals to communicate information about patients. So this organization has all that data. So Community Care Connections, it's an organization called Lifespan, sends them the 500 patients they have. And then these guys go through the data and say, oh, Jose Pagan was hospitalized twice. And then they attach that data and they create a data set. So I'm not going to go through this, but this is the kind of thing that we help these organizations with. They know what they do, but we help them to visualize what they do, which is something that looks deceivingly simple. But when you go ask someone, what is it that you guys do? They cannot put it into simple boxes and arrows or a framework. So we do, I just wanted to show you this as an example on how we do that. This one shows you the type of services that that patient had. A man, 67-year-old male with diabetes. The improvements that they expect from these services that this person received, and what are the health outcomes and long-term impact of helping that client. And here's another example of work that we have done like that, where you're trying to visualize basically the patient that joined the program in April of 2016, and they had an inpatient hospitalization and an ER visit, and then after they have no hospitalizations or ER visits. Many times, as simple as this may seem, many of these organizations don't have the experience, I would say, or people with your skill set that can help them with that. And here's another example that I won't go through it, but it's like, this is basically what we give them, the organization, and they take this to the state, and the state loves it because then they see, oh, 3 to 1, I like that, and then you can explain how you got the number. So it's a combination of not only the technical side, but how do you visualize that data. So those are the first two examples. Any questions up to there? Okay, so I'll show you the last example. I'll show you like a couple of slides. So the last one. The second example is, it's actually pretty interesting stuff. I can talk to you later about this. So the state of New York got a $100 million grant from CMS to basically revamp the healthcare system. And revamp it basically by adopting what they call an advanced primary care model, which is basically saying, can you get every practice, every doctor to practice, to be set up as a patient-centered medical home. So you see a patient, but now the patient has a whole team of people that they care about that patient. You use IT, you use data, you collaborate with partners, you use community health workers, you use all these things. That would be like a patient-centered medical home. But the state is saying, now we're going to take it a step further. We're going to call it an advanced primary care model. And what that means is that they're saying, not only are we going to do that, we're going to get all payers in the state to do value-based care, to care about it. To basically say, I'm going to pay you know, if you have a community health worker, or if you do anything connected to value-based care, episodes of care, bundle payments, I'm gonna contribute. So you can imagine how complicated this is to get every payer, every health plan to say, I want to be part of it. So what we do is we have the contract to do the evaluation of this grant. Okay, so the feds give the money to the state, 100 million. We get a contract to analyze data on this. So the same thing, you know, guess what? The other project helped us to learn about how to put together this proposal. And basically we do interviews and so on, and then we analyze claims data. But you can imagine this is a much more complex project. So on that one, I've learned that when I don't know, I contract somebody to do the work, right? So and because you're writing a budget in the air, you know, you're dreaming, you know, you give your partner, like, you say, okay, I'm gonna pay you $1 million to do this, or whatever, $100,000 to do it, and it's all paper, right? So, and then you get the grant, and you gotta do it, right? But it's important because, you know, you're farming out the work that you usually cannot do. The partner that we have on this project is an organization called Fair Health. And Fair Health basically has massive amounts of data that they analyze, and they have a lot of folks with degrees like the ones you're getting, basically analyzing data. So I'll show you an example of what, I don't want to take, I think I gave you enough on that. So we do interviews, we interview how this thing is working. So the payers may say, I don't want to get involved in this, or, you know, so through interviews they find out which payers want to be involved and what are the issues they have. Obviously the biggest issue is like, there are 10 health reform things going on now, why are you asking me as a state to get into one more thing? This is complicating my life. That's what payers say. And providers, of course, say the same thing every time, because there's a lot of different models that are being implemented. So going back to the data, so what we want to do is compare basically, you know, before an intervention happened, like this model was implemented, you have a practice, you look at cost of care, you look at data after, and you're interested in knowing what happened to practices that adopted this advanced primary care model to those that didn't. And because we have claims data coming every quarter to do this. So we're building basically a database with quarterly data that basically tells me some outcome about the practice. So we're looking at cost of care, ED visits, hospital admissions. These guys know how to calculate these episodes of care, which is even more interesting. So I can know for a patient that has, for somebody that has a hypertension episode, I know how much went into that, and I know which physician is managing that patient. And just to give you an example of, this is what we used to explain to the state, the different data sets that we combine. But to show you how the data looks like, so you see what I'm talking about. This is a good example of it. So what we did is we said, if I'm a doctor providing primary care, then many doctors do primary care, even if they are a specialist in a way, right? Because if you have like a health condition, they may see you for your usual care. So we said, if there was a claim, if you have a patient that had some preventive visit to a doctor over a 2-year period, that patient gets attributed to that doctor. So let's say that all of you had a preventive care visit with me over the last 2 years. Not only that, you have most of your preventive codes are attributed to me, let's say. Then you all are attributed to me. So then I'm in charge of managing all of you. And what we did is then we said, okay, now, and then I must see at least 30 patients. And it's just a rule, I could have picked 10. So if I have 30 patients, then it means that most of the day, that's what I do. I do a lot of this, you know, if I see more than 30 patients. So what we're trying to do is to say, the state of New York has, in this is commercial insurance, so it doesn't include Medicare, Medicaid. But we have data on 11,000 providers from Fair Health. And we basically know that the average charges per member, and again, this is like total charges for all of us, divided by us as the denominator, it's about $6,200. So over time, we want to be able to say, if you didn't implement, we don't have the data yet of who's an advanced primary care clinic, but we know who is recognized as a primary patient-centered medical home, because that's a recognition that a lot of people use. And interestingly, what you see here is, for example, expenditures per patient are in this population $7,000. For somebody that goes to a doctor that is not recognized, to in this case, and there are different categories to $4,500. So it makes some sense. So at the end of the day, we're going to be able to report this per quarter, and then run 20,000 regressions on that. So. This is just more information, So we're thinking about maps, so if you learned a lot, there's a job for you there, if you can do these things. We don't know how to do it well, so we're learning along the way, but we have 2 years to learn. Or as long as they don't take away the grant from us, of course, the contract. But, charges per region, they're interested in that. Charges by recognition of patient-centered medical home, and so on. So this presentation is a presentation we did for the state on how to do this work. I think I'll stop there. I probably spoke more than I said I would. Any questions on that?
I would add a
Comments?
comment
Yeah.
in that healthcare is by and large provided locally, and geomapping is a very useful skill. So although we will be telling you all you need to learn data analysis tools, if you throw in a geomapping tool, that's wonderful.
These studies, and it's hard to find. I found it hard to find people that know how to do it, and then not that they know how to do it, but that they know how to sort of like think through the problem in an applied way.
Yes, this is something probably the urban planning department has a better handle on than the public health. So maybe we need to collaborate across schools.
Well, are there any questions for Dr. Perez? If not, I'm sure you can get in touch with Dr. Perez later if other questions come up. But let's switch.
He had a question.
Oh, sorry.
So basically, what is being done above a patient-centered medical home?
Above.
What is a part of this advanced primary?
Yeah. So a lot of it is the payment side. So the typically to get recognized as a patient-centered medical home, you have to meet certain standards. But that's for the practices, the combination of doctors that belong to a practice. What the state wants to do is to get payers involved on top of it, and they want you to. So if you provide care, you may have to go into contracts that you're not used to as a practice, and take some risk. So in that sense, it's a little bit above what PCMH recognition entails.
But backing up a step, for a medical practice to get certified as a patient-centered medical home, the idea is that, well, let's use an example. If you go to the doctor and the doctor puts a blood pressure cuff on you and says, oh, your blood pressure's high, take these pills and come back next year. And maybe you go to another doctor the next week who treats something else in a similar fashion, and another specialist the following week who does something similar. There are several problems with that. First of all, no doctor is spending the time with you that's really good to give you the information that you need to manage your disease. But second of all, every disease is being treated in a silo. So the idea is in patient-centered medical homes is that a patient should have one place where they can get the super majority of their care, which will include not only excellent medical advice, but the social supports that they need to manage their diseases. So it's not just having a good doctor. A good doctor is a wonderful thing, but having staff people who advanced practitioner, nurses, physicians assistants, social workers and such who can support the patient. Having accessible hours. You know, if you're only open 5 hours a week, that's a little challenging. You know, at the very least, there should be a phone number patients can call 24 hours a day, because we don't all get sick on schedule. And so, and there's a whole set of guidelines and a process for a medical practice to be declared a patient-centered medical home. But then, said, why would they do it? Well, there has to be some money attached to it. And in this case, there's $100 million.
That's just to convince them. Oh, yeah.
The entire system is struggling right now with how do we take better care of patients, not just give them good advice in 5-minute increments, but have it implemented in their lives. I don't know if you saw this, anyone saw that this week. Obesity is hit a record high in the U.S. and is approaching 40% of the U.S. adult population. That itself is a problem.
Well, following Dr. Perez is a little bit, I'm going to talk about a little more boring things. But I think his examples were really powerful on just how important claims data can be, because the kinds of information that you can get from surveys, where you go out and you talk to people and you fill out the questionnaire once a year, is dwarfed by the volume of data, because there's no way you can survey everybody in New York State, but you can get claims data on pretty much everybody in New York State, or pretty much everybody in the US. And so we're going to talk about how to get that data. And I'll try to get some examples along the way, but this is kind of on the level of business and who owns what and who has rights over what. So this is a really important issue. One of our staff members just yesterday sent in all of our paperwork for us to get the Medicare SEER database, which is a cancer registry linked to claims. So knowing how to get that data is really important. So a couple of things here. There's really two questions. Who owns it? Because there isn't data about claims that's just out there on the internet that's really very useful. People know why. Why isn't that data out there? For one thing, if you had that data, you could invade privacy. With the kind of detail we're talking about, you could figure out individuals and names, and you could find a politician that had mental health treatment, for example. Not that we think anyone ever does that. So we have who owns the data. It's either private, even the government-owned data comes with restrictions, and there's sources of that. There's the payers like the Medicare program, the Medicaid program, Excelis, the Blue Cross Blue Shield plan in Rochester, all own data. Large employers own data. But why do employers own data? Claims data?
If they run their own healthcare plan?
Yeah, exactly. They pay for health insurance for a lot of people, so they have the data to justify what they're paying. And health systems like NYU Medical Center, for example, has a lot of data on the patients they see.
And also their employees.
Well, that's right. hopefully the medical center doesn't have that, but the NYU as a employer has that data. So that's who has it, but the question of what are the conditions that come with getting a hold of that data? Well, there's a price. There's organizations that assemble this kind of data from many different insurers and many different employers, for example, and that's a fair effort and that has commercial value. But even if you go to the Medicare program or the Medicaid program, they will have a process to go through, but it comes with some dollars. But this other issue here, the intended use, I think, is very important because what is your intended use? If you say, well, I'm going to use this data to figure out patients that the drug company I work for can sell the drugs to, that's probably not something that most organizations would want as an intended use, right? There's privacy violations, there's all sorts of issues with marketing to individuals that we broadly as a society think is bad. So a couple of things we're going to go into a little more detail on these. So one of them is a bit more on who owns the data. And there's really, our healthcare system is siloed. If you're living in the United Kingdom, which I was a few decades ago, there is the National Health Service, and it covers everybody. But in the United States, there's no one system that covers everybody. We have Medicare for people who are over 65, mostly, or disabled. We have Medicaid for people who are low income. We've got commercial insurance, which is by far the biggest, and that's for people who have commercial insurance usually bought through an employer. So, and then there's some others, and I think students, as NYU grad students, they probably make you buy insurance, right?
Yes.
Who do they make you buy? Like United Healthcare or something like that? Optum. Yeah. So you kind of fit someplace maybe between here and here, as student insurance programs are kind of special, and I think they're exempt from some of the ACA, the Affordable Care Act rules. So it's one of those other kinds of programs. But one of the problems in talking to people who are so much younger than me is you're mostly all healthy. So because you're all healthy, you sort of don't appreciate the volume of doctor visits that someone who is like my age and has diabetes and just broke their leg or something like that. Those people can literally have a few thousand claims in a year. So you have someone who is interesting from a health standpoint, right? Someone who's perfectly healthy isn't very interesting, right? But if someone's a diabetic and they've gone to the hospital or emergency room, there's a lot of information every single time they get a lab test or they walk into their doctor's office or fill a prescription drug or anything. There's a record of that, and that's the value of this kind of stuff. So this is fragmented data. So you don't ever get a full picture from any of these, but boy, you can get a pretty full picture about the silo of this data.
I'd like to make a comment about the Medicaid data. We speak of Medicaid as a single entity, and whereas there's commonalities across the states, they are state-run programs, and there are 52, even though I know there are 50 states, but there's also DC and Puerto Rico.
I forgot Guam.
I'm not sure Guam has a Medicaid program. I haven't heard of it. I'm not saying it doesn't. But Puerto Rico certainly does. It's one of the bigger ones, and DC also. A lot of heterogeneity between the Medicaid plans.
So the one that's the most consistent actually is Medicare. It's the closest thing we have to a single payer, but even there's the split that T indicates. There's the traditional fee-for-service, the traditional Medicare program that was started back in the 1960s. And then there's the Medicare HMOs, also called Medicare Advantage plans. And they now have about a third of the beneficiaries are in those managed care Medicare plans. So even there, they talk about Medicare for all. Do they mean this? Do they mean that? Or some of the other variations? So this gets pretty interesting from a policy standpoint. And there's data to back up the different thinking about policy. Well, talking a little bit about how much of the population is in each segment. So we have private Medicare, Medicaid, uninsured. By the way, the uninsured are particularly difficult because nobody has good claims data on them because nobody is paying. So the payer, when someone who's uninsured goes to a doctor, they may pay out of pocket or they may pay not at all. And because a company is not paying, like an insurance company is not paying, the tracking of that event isn't as good. So one principle here is the data is better if there's money attached to it. So real broad principle, but that's okay because for the most part nothing happens unless somebody's paying for it. So get used to the dollar signs in this data. It's really very useful, very important information. But most people under 17, lots of them are private insurance. A big portion is Medicaid. About half of the babies in the United States are paid for by Medicaid. About half of the deliveries. So Medicaid is very, very important for people, population basis who are very, very young. But in the 18 to 44 and 44 to 64, the vast majority are covered by the commercial insurance. What's sort of interesting, you think of, and for over 65, Medicare is the vast majority, almost everybody over 65. But there's some people covered by Medicare who are in the younger than 65 group. People know why? You've answered all the questions.
End-stage renal disease?
That's a chunk in here. Congress made an exception for coverage for people whose kidneys have failed, and this was done, I think, we have handled in the 70s?
It was before I was born.
60, 50, I'm sorry.
I don't know.
It was when Reagan was president, right? Was Reagan?
No, Nixon.
Before.
One of the ones.
So there's other reasons people are in here. The biggest population is people who are disabled and can't work and qualify for supplemental income can qualify for Medicare. So this is, you can see a different slice of the silos here, right? The previous one was the.
And one of the points is that depending on if you have an interest in a population that's of a certain age, and you need to correlate the two. So if you want to study children, you don't go to Medicare data.
Well, just some examples of some of the sources that we go through, and I'm supposed to hand this over to you.
No.
early point, not yet?
At whatever point you feel comfortable with, it's up to you.
Well, I think the number is slide 8. Let me see if we've
Yeah,
got
there's
it.
another section. There's a
Oh,
section
okay,
about
so
it.
this is
You'll
still,
get there.
still beginning. So we talked about who owns the data, and this is another cut at some of the data that's available. In some states, there's what's called all-payer claims data. And Massachusetts, for example, has an APCD database, and they've gotten contributions from all the different payers in the state, and that's available. Unfortunately, none of these really have all the data. There's exceptions. So when you go into and you try to do some work in these, really knowing the details of who's in and who's out is really important. Medicare Expenditure Panel Survey, MEPS, we often see studies that are done from MEPS because it is almost free from the federal government. It's easy to work with. It has dollar signs on it, and it's real small, and it's supposed to be statistically balanced. But it turns out it doesn't quite represent what costs are. It's based on survey data, but it's used for a lot of research because it's inexpensive and easy to work with. So you'll see a lot of studies using that. Insurance company data, as you've seen, there's a lot of sources for that, a lot of studies. In our world, we have in our server at Penn Station, one data set with about 30 million commercial lives and another with about 20 million commercial lives, and they're different. So we have this over years, and it's longitudinal. So we've got a good, healthy chunk of the U.S. commercial population with, just literally billions of lines of data on what happened to these people. So we can follow someone, for example, what comes to mind as a rare chronic disease for you, like a rare disease?
Hemophilia.
Hemophilia. So we found tens of thousands of hemophilia patients in this data, and we can follow them for years in the data. So you can actually see the progression of diseases, how people might over time, the more comorbidities they have increase. You can actually watch that with hemophilia. It's that nature of the disease is that people get problems with their knees or other joints because hemophilia is the blood doesn't clot properly. Well, that doesn't just affect if someone gets a cut or something. It affects people if just walking around there's stress on joints and their joints deteriorate because blood is leaking into the joints. So that's an example. These are hospital discharge data sets. So New York State, you get this data from the state. It has every hospital discharge in it, and it has some information on the patients, which is useful. So you can tell, for example, the number for each of the hospitals in New York State, how many patients get discharged with a diagnosis code of an infection. And that could be, you might think that could be used to see if the hospital's generating a lot of infections. Right now, who can think of why that's probably not a good way to study infections? Right. Well, it turns out that hospitals don't like to admit they make mistakes. So the coding for hospital claims, the diagnosis codes are used to generate payment. And so there's not really much of an incentive for them to track that data. Finally, billing system of a hospital, NYU Medical Center, they have data. Obviously, if the patients that came there and they're sending bills out to the patient or the insurance company. The challenge is that if the patient goes to NYU Medical Center for an emergency room visit, but they go to Mount Sinai for the surgery, NYU and Mount Sinai are maybe not the best of friends and probably don't share their data. So just getting the NYU Medical Center data may not give you the complete picture of that patient. So a couple of things. How are we doing in time?
We're running a little low on time. We have
Low.
about 7 more minutes.
So-
This
so-
is your last slide.
This is my last slide. Okay, so most of your time when you get into this stuff is going to be trying to figure out how to work with it. In theory, there's standardization, and whatever data set you learn first is kind of going to be your standard for a while. But there's always differences from one data set to another as you go through this. But the differences, could be pretty broad. There's of course, the population differences. You don't see maternity in Medicare, right? You see it in commercial data. You don't have there's very, very few children who are covered by Medicare as well. So there's those kind of differences, but there's also differences in how the claims get processed, but really big differences in the dollar signs. So Medicaid pays a lot less than Medicare in most places. And Medicare pays a lot less than commercial insurance. So when it comes to doing a cost-benefit analysis, that can have a really big impact on, is the data you're working with understanding the different ways that the payments are made. So that's my last step.
Yeah, so at the beginning, Bruce sort of divided the question to obtain claims data. You have who owns it, but then also under what conditions would they be willing to share it with you, right? Because we've talked about all this very private information. If you want to get access to the claims data, you need to know who owns it and who you can ask for it, but also sort of why they would share it with you. And so I think it's important to remember that there's really no free access to claims data. All claims data that's detailed, and we sort of went over this at the beginning, to be useful is going to be protected health information, right? So there's these different levels of PHI. There's some data that's fully identifiable, so it'll have your name, your birthday, your social security number, sort of everything about you that you could identify an individual person. There's also a level that we often get that's called limited data sets, which are not considered de-identified, but they're potentially identifiable. So that means, there's still individual patients in them. You can sort of follow them along. They have the same identifier. It's not their social security number, right? But it's another made-up number that follows one patient. The reason usually that people consider those potentially identifiable is because if you think about, if you're asking a really specific question, some people have rare diseases, some areas of the country don't have that many people in them, you can actually figure out which individual person that is, right? You could say, it's like the one woman in Billings, Montana that has hemophilia, it's Susan down the street. And so those are considered potentially identifiable. And so obviously whoever owns the claims data is trying to protect it, and there's only going to be some situations in which they distribute that data. So I think what we're trying to get at here is that you actually have to have a reason to use the data, right? You can't just go to Medicare and say, I would like to have some data because I think it would be interesting, and I'm, for personal benefit, going to be analyzing it. And so there are several reasons why you might, in fact, get approved to get access to this kind of data. One would be if you're working on behalf of the person who owns the data. to do work that they would otherwise do themselves, right? So for instance, I used to work at the Medicare headquarters, Centers for Medicare and Medicaid Services, and so sometimes we couldn't do all the things that we wanted to do, both because we didn't know how or we didn't have time. So we hired contractors, and we would hire the contractor to do a task that we wanted done, and we would give them the data because we said, you know, we want to analyze this thing, so we're going to ask you to do it. So we would contract that work out. So we at CMS owned that Medicare claims data, but we asked someone else to do the work for us. Sometimes people have research proposals that are totally separate, right? So you might want to study something that Medicare didn't say, oh, I want to pay for that, it's super interesting. But if you have a reasonable research proposal that they feel will sort of benefit the Medicare population in some way, you can propose to them a research project, and they'll review it, and they will let you purchase the data for that use. But I think the general sentiment here again is that data exploration and learning is not really something that you're just allowed to do. If you request data because you think it might be neat, they'll say no, generally speaking, as they should, because it's protected health information. So we've talked about most of these data sets already. I think what we wanted to get at here is sort of these are the data sets that we would most often see researchers using, right? So I think there are some situations, and Bruce talked about this a little bit, there are commercial claims databases that you can buy, right? So commercial payers will sell their data to aggregators, and the aggregators will let you buy that data. And we do use that sometimes with commercial populations, but for research purposes, these sort of Medicare sources are generally speaking what you'll often see studies written about when you're reading journals and things like that. So we talked about the MEPS data, which is again sort of claims-like as opposed to claims. These 3 Medicare data sets, which are of different sizes, but they're the same idea. It's a data set that has some subset of the population, either 5%, 20%, or all of them. And there are some differences between those, which I think we talked about a little bit already at the last session, but I think generally speaking, those are relatively low cost. For the amount of data you're getting, like, it's not like it's $100, it is in the thousands of dollars, but it's not $100,000, right? And you can get this data for research purposes. I think Tia sort of touched on this with this idea that the Medicaid data is owned by the states, and you can get it potentially from every state, but it really depends because it's a state-by-state program. So each state is holding their own data. We have these sort of APCDs and the VA. So thinking about, you know, obviously, what you want to study is going to strongly inform what data set you need to look at, right? Because if you want to study maternity, you probably shouldn't ask for Medicare data. It won't have the right population. But you also need to think about sort of the cost. And I think I'll say, as an anecdote, when I was working, I worked at the CMS Innovation Center, which gave out a lot of money to lots of people, including the State Innovation Model program that Dr. Pagan referenced. But we were trying to develop payment models, and we wanted people to sign up. And so similar to the discussion we had about patient-centered medical homes, we were running a program that we were trying to get people to sign up for bundled payments where they would take on some risk for a collection of services. But most providers would say, you know, I'm a hospital, I'm thinking about taking on risk for this thing, but how could I possibly know if that's a good idea because I don't have the claims data for all the things that are happening to that patient. And so they decided sort of internally at Medicare that we should just hand out data to people who thought they might want to participate in this program. There's a lot of political buy-in for that idea, like, oh, providers are interested, they're all actually Medicare providers. So that's like, there's a path for providers to get data for certain reasons. So they said, we want to do that, but there's really only 2 reasons legally that Medicare was allowed to give out data, and one of them was research. One of them is called healthcare operations, right? So you have these 2 buckets. Is it for research, is it for healthcare operations? And going down that path of sort of trying to convince a lot of lawyers at the government that it was legitimate research to give providers financial data to figure out how much their patients cost was very difficult, right? Because it was sort of like, but they're only doing the research so that they can figure out if they're gonna save money, and so then they'll sign up for a program. Like, is that really research? They're not gonna publish it, like who's gonna benefit from it? but it's also not healthcare operations because they don't need the data to provide care to a patient, right? And that is a reason that they will give out data to folks, which like probably won't be one that we'll receive data for in this lab, but and I think that was, and we did actually succeed and gave out an enormous amount of claims data for free, which is to this day still terrifying to me that someone's going to find me and tell me that what we did was wrong and I'm going to jail. So I think this is just, we have also collected a number of different claims data sources. Again, these are largely, we use them for research purposes, so we have some commercial data that we buy and we have sort of collected that's all for research purposes. So this is outside of the Medicare claims that we have. We also have proprietary data sources that we've collected. And so thinking about sort of how did we obtain that claims data, I guess it's sort of this idea that we service clients for various business reasons, and they basically have said, you know, if we negotiate a slightly lower rate for the service that they're purchasing, we can keep their data and de-identify it and use it for research purposes. And so that is something that we do, but then that puts a burden on us to very effectively de-identify it, which we do. So for this lab, we're planning to use a smaller, older, and more de-identified subset of the Medicare 5% sample, which Medicare does make available for training purposes. So it is fine for training. So to the extent that what we're trying to do here is give you sort of the tools that you would need to figure out how to do claims analysis, we think it's going to be okay. In terms of actually doing sort of like useful publishable research, it will usually not be sufficient for that purpose, and we can get sort of more into that. But I think that brings us to the idea of like, where are we going from here, right? So we've already had these 2 sessions to talk about what is claims data, sort of how you can get access to it. And so our plan for the next session is to go into sort of a more interactive session to talk about example research questions based on your interests. So what are you interested in studying that you think is a question you could answer using claims data? And I think we can discuss those, sort of what are the pros and cons, what are the different data sources, and if it's feasible. So that is the idea. So I'm just like warning you now that you have a little bit more than a month to think about sort of what kind of research questions you might be interested in. Keeping in mind that like sort of starting from a broader perspective is certainly fine. We're not going to be disappointed that you don't come with a fully baked research idea that's, you know, implementable in a data source you already have. I think that is not our expectation, but rather to sort of talk through some of the issues that go along with doing this kind of research. So that is the end. We are over time and you are all very attentive, which is wonderful. So do you have any questions for any of us?
I wonder if all the data from health claims are like the sources, the data you gather from all sources, are they raw data or they have been partially processed for our own needs?
The data that we're going to use for this lab, you mean?
No, for
like the Milliman data sources that we talked about. Mm-hmm. So we collect them in raw form, right? So like we internally, I mean, we have both. We have raw claims data files and we have processed claims data files.
Oh.
And they're good for different reasons.
That's a great question.
Really, yeah.
Because you know, when insurance companies go through a process of, you know, deciding to pay, how much to pay or not, and all that stuff, we typically get it after all of that.
So the data is the data that we get that we call raw is post-transactional. So it's after all the money's been settled up, we get a record. But then it comes in and, well, if it goes to Medicare then scrubs it to some degree.
They do. And
then the data comes to us, but still it's the data that we get, whether it's from Medicare or elsewhere, is pretty close to its original form. But then internally, we add a lot of value to it. We group it the claims into categories. We add risk scores. We do this. We do that, and then we create what we call processed data. But we don't throw out the raw, because if you go back a slide, there's this concept called transformation in data analysis, which means that, you know, every time you change data, that you transform it from one state to the other, things happen to it. And those can be good things, but they can be bad things too. So like just this week, I wanted to do something with Medicare data, and I was looking at our process data, and there was something missing. And sure enough, there's data, there's a data element that comes in on the raw data that by the time it gets to the process, through the end of the processing, has been dropped.
So I think this is a really confusing question in addition to being a good one, because I think we all answered it in different ways. But in short, there's processing that an insurance company or a payer does to a claim. So that's like the process that they go through when someone says, pay me this much, and they decide if they're gonna do it, right? So that's what Tia is saying, she's referring to as transactional, right? So they deal with all of that, and then it pops out a claim. And so we are generally getting that, which I would consider a raw claim, right? But we then add processing, data processing on our side. So we have the whole set of raw claims, and we'll sort of do some internal stuff to add fields, which I think a lot of people do. If you're doing claims data analysis a lot, you know, you'll be doing the same thing over and over again. So you always want to know the total amount of a certain claim, right? And to get that amount, you always add this field and this field. And so you just add it to your data set. So you don't have to do that over and over again.
I mean, like sometimes if they already process their raw data, we would have different sets of like standards. Like that will like mess up the whole calculation if we want to like add stuff on top of it.
They typically will give you, depending on who you're working with, they'll tell you, okay, we took out claims connected to behavioral health, mental health, because that's too private, we don't want to give it to you, or testing, genetic testing. So you sort of like know a little bit about some of the scrubbing. But there's some other issues that come up, like let's say the person keyed the information at some point before the data came in, like errors in the data.
Right.
The person fell asleep at the key. So there's an error. There are errors that happen in billing. And then, so in a way you still have to go through it and process it to pick those things out.
The dreaded 9999 code that has millions of dollars attached to it.
Or inconsistency in coding and a lot of things.
Is there a data book for this data set, or?
So the data that we're going to use, in fact, at some point we gave the URL, but we should do it again. If you can Google it though. If you do Medicare claims data PUF, public use file. There's not just a data book. There's a whole list. There's training sessions and PowerPoints and videos, and that's why we want to use it, because they have built a collection of materials around it. But in the real world, when you move out of the training set that we're about to use, every time you get your hands on new data, the first thing you want to ask to whoever's passing it to you is, where's the data dictionary? And everything else you can give me in words about the data. And unfortunately, sometimes people go, yeah, but.
It's also really important to make sure you're using the data dictionaries from the right years, because a lot of things like Medicare data and things that we get, they'll be sort of continuously improving their data and things, but you'll get changes in variables, changes in a variable name, variable type, things like that. So you don't want to use the 2013 data dictionary if you're looking at 2016 data, because then you can develop a whole methodology or a code or whatever, and then you go to run it, and half that stuff is either those variables don't exist anymore, or it's been renamed, or it's in a different format. So it's really important to make sure that you're using the same year.
So your week will be easy?
The PUF files are actually, I think, more than 10 years old. I mean, but you know, they, once again, for what we're using them for, they're fine. Because the skill that we're trying to teach you is read the documentation, whatever it is, and we're going to teach you how to read the documentation.
So we actually have a box sync folder that has everything you need downloaded. We just need to check with IRB on NYU side, but then we'll send that link out to you guys so you can have all of that stuff. In follow-up to this session, Evan will be sending out, he doesn't know yet, but he'll be sending out an evaluation for this session and session 1, and then for those of you who didn't attend session 1, the link to the video from the first session.